today. I thought I would talk a bit about what are the risks of not having hormones and why are some people told that they can't have them if they want them. Because for many years, in fact decades, women have been scared away from HRT, often for the wrong reasons. And when we say HRT, it means different things to different people, including to different doctors as well. So HRT, hormone replacement therapy, usually means the hormones that we give to women who are perimenopausal or menopausal or who have hormonal changes. Now there are different types, there are different doses, there are different formulations, there are different preparations. There are many hormones that we produce in our bodies. We have hormones such as insulin or thyroxine. They are hormones, but I'm not going to talk about those. All I'm going to talk about is those three important hormones, estradiol, progesterone and testosterone. Now we know that we produce them in our bodies. Men and women produce those hormones. Quite weird to think that men produce estradiol and also women produce testosterone. They are derived, as I've said before, from cholesterol, and cholesterol forms progesterone, and then progesterone forms testosterone, and then estradiol comes off that. But also our stress hormone cortisone will come off progesterone too. These hormones have really important biological effects throughout our whole body and affect every single cell process and every cell in our body. So it's very important that we have them. Now, obviously, with age, our ovaries don't work as well. So the ovarian function declines. So the hormones estradiol, progesterone, testosterone decline as our ovarian function reduces. Testosterone usually reduces with age and often starts reducing actually often late 20s, early 30s. But we produce these hormones throughout our body. We make them in our brain as well. So they're not just ovarian hormones. There's been a confusion for many years because when we say HRT, lots of people think, what are the risks? Now actually, there are lots of hormones that we prescribe that are synthetic, that are chemically altered. And this has been going on for many years, almost a century, when they started to market hormones to women. And they obviously produced HRT many years ago, but they also produced synthetic hormones in the form of contraception. Now these hormones, the synthetic HRT and contraceptives, have been chemically altered. So it means that structurally they're different. They don't work the same as the biologically active hormones in our body. They work differently. And so therefore they don't stimulate the receptors in the same way in the cells. They don't have the same biological effects in our cells and bodies as well. So they do have risks associated with them. We know that contraceptive and synthetic HRT have a small risk of heart attacks. They have a small risk of clot and stroke as well. And they possibly have a small risk of cancers. But this is the synthetic ones. Most people aren't so worried about the risks in contraception because usually contraception is obviously given to younger women who have a low risk of all these conditions. But as we get older, we have an increased risk of all diseases. And so the risk actually will increase as we age. So to add a risk is something that's not very advisable for many people. So actually in our clinical practice, certainly in my clinic, we tend not to prescribe the synthetic hormones because we've got safer alternatives. And this is really important to know the difference. So usually when we prescribe HRT, we prescribe the natural body identical hormones, which basically means the hormones are the same chemical structure as the hormones that we're replacing. So the hormones we as women produced when we were younger, we're just replacing like with like, which is really important because then we don't have those risks. We don't have the risk of clot and stroke and heart attack the way that we prescribe natural hormones. And so it's very important, if you are going to take HRT, to sit down with your healthcare practitioner and say, what type of hormones am I taking? Are they synthetic, i.e. chemically altered, or are they natural, as in, are they the same structure as the hormones I produced when I was younger? These natural hormones are available on prescription through the NHS as well if you're in the UK, and they are usually derived from soy or yam plants. So they are very safe. They are the safest thing I've ever prescribed as a doctor, and they are essentially natural because we're just replacing like for like. So because they don't have the risk of clot and stroke and so forth, it means they're a lot safer for women to take. Quite a few of you have sent me questions saying, what are the alternatives? Because I've been told I can't have HRT because I've had a clot before, or I've got a risk of stroke, and my doctors told me I can't have HRT. Well, you can't have synthetic HRT because I've already said there's a risk of clot with those or stroke, but the natural hormones you can, and there's lots of information. I've done YouTube videos before, I've done podcasts before, there's lots of information on our Free Balance app as well and on the website talking about this, and we've got a patient information booklet that I've co-authored with Thrombosis UK, talking about the safety of natural hormones for those people who have an increased risk of clot, just to reassure you as well. Some people think that they can't have HRT if they've got an increased risk of cancer, if they've got a family history, for example, of breast cancer. Actually, these people still usually can take HRT because the natural hormones haven't been shown to be associated with a risk of cancer. Any risk of cancer, including breast cancer, has been shown with synthetic hormones, especially the synthetic progestogens. And we usually prescribe the natural body identical progesterone, either orally or as a pessary. And so that gets absorbed and metabolized in the body as the pure progesterone. So it doesn't have that risk. So somebody, if they've got an increased risk of cancer, maybe because of an increased family or family members have breast cancer, it means your risk of breast cancer might increase regardless of whether you take HRT. So taking HRT, it won't usually increase that risk further if you're having body identical hormones. Now, I've already said many times before that women take HRT really for two reasons. One, to improve our symptoms, because the symptoms for many of us can be really harrowing and affect the quality of our life. But the other reason that we prescribe or we take HRT as perimenopausal or menopausal women is to improve our future health. We know our hormones are anti-inflammatory, they reduce inflammation in our body, they help our organs to work better, they reduce our risk of diseases. We know this for many years, and in fact it's people who take HRT have a lower risk of osteoporosis, and in fact HRT is licensed as a treatment to prevent osteoporosis. Osteoporosis affects around 1 in 2 women, so it's very, very important that we look at ways to strengthen our bones. So we need to then think about, well, what are the risks of not having HRT? The majority of menopausal women globally are still not offered or prescribed HRT. Even in the UK, the majority of menopausal women are not being prescribed HRT. Is it because they don't want it, or is it because they don't understand it, or is it because their healthcare professionals haven't had training? And it's often a combination of those things. Many people, including lots of people I communicate with, are being offered and prescribed antidepressants instead of HRT. But let's look at antidepressants. They have a role in people who are clinically depressed. But for people who have low mood and anxiety associated with their low or changing hormones, they're not going to have an effect because they're not treating the underlying cause. The cause is related to changing hormones. And so they are not licensed, they're not recommended to use for the low mood associated with perimenopause or menopause. Yet in the UK and many other countries, women are routinely being given antidepressants. Now, antidepressants aren't going to improve the symptoms, like I've just said, but they're also not going to improve future health. And in fact, we do know from studies that antidepressants are associated with an increased risk of developing osteoporosis as people take them. I've already said menopausal women have an increased risk of osteoporosis. Why would we prescribe something that isn't clinically effective and is going to increase the risk of osteoporosis going forwards? It just isn't logical in my mind. So if you are being offered antidepressants, absolutely, if it's for a psychiatric disorder and your doctor thinks that you have a condition that would benefit antidepressant prescribing for, but if it's for your menopausal or perimenopausal symptoms, or even your symptoms of PMS and PMDD, you should be asking why you're not offered and being prescribed body identical hormones, which have more evidence to support both improving symptoms and future health. So we need to be thinking about the risk to our bones, the risk to our heart. We know there's an increased risk of a heart attack for people that don't take HRT, increased risk of dementia, type 2 diabetes, autoimmune diseases, osteoarthritis, mental health disorders such as clinical depression, bipolar, schizophrenia. All of these increase without our hormones. I know it sounds very depressing, but this is just fact. It doesn't mean we're all going to get these diseases, but it's just a way that we should be thinking about it differently. It's a bit like thinking about not exercising. I've spent all day working today preparing for my presentations that I'm going to give in Australia, and I realised an hour before I did this that I've just been working all day, hardly moving. So I went and did half an hour's yoga, which, you know, it opens up my body. I feel better for it, but I know it's improving my bone strength, it's improving my heart, and it's also improving my brain. So we need to be taking responsibility for our health, and sometimes that means taking something as well, including hormones. Now, so we should also be thinking about if we're being offered other medication. So there are non-hormonal treatments which may or may not improve symptoms depending on what symptoms you have. Most studies have looked at vasomotor symptoms of flushes and sweats, and we know they are not the main symptoms that affect people. The majority symptoms are symptoms that affect our brain. However, some people are still prescribed drugs such as pregabalin or gabapentin, or there's a new drug that a few people have asked about called fezolinetant, which is a neurokinin receptor antagonist, which is a new type of drug, which at the moment is only available privately. Now, we don't prescribe it in our clinic, and that's because I'm very nervous about the safety data for this drug. We know that it can affect the way the liver functions, and some people have abnormalities in their liver test when they're done as a blood test. There is a study in the Lancet that shows that people who take fezolinetant have an increased risk of having epithelial cancers, a type of cancer. So I'm not convinced enough to reassure patients that it's probably safe to take. In America, there's an FDA black box warning because of the liver or potential liver damage with fezolinetant. So I think if we are being offered, when I say we, I mean as menopausal women, if we're being offered drugs that aren't hormones and aren't natural body identical hormones, we need to be speaking to our healthcare practitioner and saying, could you give me the evidence? Could you give me any data regarding both benefits for symptoms and future health, but also potential risks as well? Anything we do, there's going to be a benefit risk sort of ratio for us to look at, and it's up to us as individuals whether we want to take any risks with benefits, but for most people the benefits of taking natural hormones outweigh any risks, and for the natural hormones it's very hard to find any actual risks. When you look at the data, it's pertinent to the synthetic types of hormones, not the natural hormones. Now, some people have asked about, what about if I'm going to have my ovaries removed, I'm young, have my ovaries removed, and then obviously they will have a surgical menopause. So they will be floored into menopause overnight after the surgery. Now, it's really, really important that if you are having surgery, that you discuss with your surgeon or your doctor before having the operation whether or not you should be prescribed hormones. I can't imagine not having a conversation with a patient who is having their thyroid gland removed, whether they were going to come out of hospital with thyroxine, the hormone that our thyroid glands make. Of course, that conversation is routine, yet we know up and down the country, and certainly in other countries as well, people are not having that discussion before having their ovaries removed. And even the audit data we did looking at 3 big teaching hospitals in London, then it was less than 5% of women were prescribed hormone replacement therapy after having surgery. I've already said there's no risk of clot with the natural hormones, so these people can usually be started straight after the operation. So there is a risk of leaving the hospital without hormones if you've had your ovaries removed, and you need to be thinking about having that conversation. Some people have asked me about, what about taking HRT if I'm older? There's so many women, in fact there's millions of women who have missed out on taking HRT because when they were perimenopausal or menopausal, the WHI, the Women's Health Initiative study, came out scaring everybody away from HRT. And to reiterate, this was using synthetic hormones. This risk of breast cancer wasn't there with the estrogen only, because that showed a reduction risk of breast cancer, and with the combination type, the synthetic progestogen with the synthetic estrogens, the risk of breast cancer wasn't even statistically significant, yet it scared people away. So there are women now in their 70s, 80s, even 90s who are either suffering symptoms or concerned about not having hormones. Now, I've already said osteoporosis is very common, and it's more common as we age. we know that the mortality from having an osteoporotic hip fracture is about 20% in the first year after having a hip fracture. That means 1 in 5 women will die after having an osteoporotic hip fracture, which affects around 1 in 3 menopausal women who doesn't take HRT. That prognosis is worse than any other disease pretty much, and most cancers as well. So if a woman in her 80s or 70s was wanting to talk about taking hormones to strengthen her bones, reduce her risk of developing osteoporosis, then it's not an unreasonable thing to do, i.e. it is a reasonable thing to do, especially having natural hormones. And so the concern in the past was having the synthetic hormones which have the risks associated with them, but the natural hormones don't have this risk. So sometimes in the clinic we'll start older people with a low dose of estrogen through the skin as a patch or gel, so it stays as the pure estradiol, with the natural progesterone, with the natural testosterone if they needed. Also, often, don't forget the vagina and the urinary tract, so often with vaginal hormones if needed. And often women then come back and say, gosh, I feel so much better, I have more clarity of thought, I can sleep better, I have less muscle and joint pain, I have more energy, I'm more focused, my palpitations have gone, my skin is better, I have less urinary tract infections, which is wonderful to hear, but also we know that even a low dose is going to help strengthen their bones as well. So there isn't a reason that an older person couldn't have a trial of hormones to see if it helps. Some people have asked about, well, I was on HRT, but I've stopped taking it. Can I restart it? For the same reason as older people can take HRT. Yes, you can start HRT, but if you're going to start it again, I would always ask for the body identical natural hormones, even if you were on a synthetic one in the past. Somebody asked about, I don't have any symptoms anymore. Can I stop taking my HRT? Well, there's 2 things to think about really. The first thing is taking HRT is a choice. Anybody can decide whether they start it, stop it, or continue taking it. If we have, if we are consented adults, if we can make decisions ourselves, then of course we can decide what to do about our hormones. Just to reassure you, the hormones don't last very long in the body. So if I stop taking my HRT now, by tomorrow evening it'll be pretty much out of my system. It doesn't build up in the body. It has quite a short half-life. That's why we have to use it regularly. And so we can decide whether we want to stop or not. We need to then, the second thing is to think about what are the reasons for us as individuals taking HRT. For some women it will only be for symptoms. Now, none of us know how long our symptoms are going to last for. It might be years, it might be decades, it might be months, who knows, and symptoms often change with time anyway. So when we're on HRT, if we have the dose and type right, we won't have symptoms. But stopping our HRT often will start the symptoms again. Doesn't necessarily restart to how it was before, but it's impossible to know. So some people find they stop HRT and their flushes and sweats they used to have might have gone, but they might find that they're more tired or have muscle and joint pains or headaches or what have you. It's impossible to know, of course, until you stop. But like I said, the other reason for taking HRT is for health benefits. So as soon as I stop, if I was going to stop taking my HRT, I might or might not have symptoms, but I know I'd have an increased risk of diseases. As soon as my body didn't have hormones, estradiol, progesterone, testosterone, I would have an accelerated bone loss. I would have an increased risk of osteoporosis. And personally, as a menopausal woman, I'm very scared of osteoporosis. So one of the reasons I take HRT is to try and keep my bones as strong as possible. It's an individual choice for me, of course, but that's a reason that I will continue taking HRT forever. The other thing to be aware of is there is some studies show that in the first year after stopping HRT, a woman's risk of stroke and heart attack increases. And that's really because they haven't got this lovely anti-inflammatory effects of hormones in the cardiovascular system. And so it might be without those hormones, there's more of an accelerated atheroma and inflammation in the lining of the arteries. So there might be risks actually of stopping taking hormones, which is something that a lot of doctors don't think about. A few people asked about endometriosis, saying I've been told I can't have HRT because of endometriosis, or if I try HRT, it flares up my endometriosis. What do I do? Now, I've spoken about endometriosis before. It's on my YouTube as well, so it might be worth listening to that. Some people find that estrogen can flare up endometriosis. The more I see people with endometriosis and the more I read about it, I think a lot of it is due to the synthetic hormones. We'll find in the clinic often when people have natural hormones, especially progesterone and testosterone, their endometriosis can really calm down and really settle. They might or might not need estradiol, but we need to be thinking about progesterone and testosterone for women as well. It's obviously very individualised, but it would be worth speaking to someone who really understands hormones as well as endometriosis. Some women with endometriosis are given an injection to just block the hormones working, which will stop any hormonal variation, but literally will floor people into menopause, and often they'll feel considerably worse. So make sure you talk to someone about whether you need to have hormones and what the right dose and type and balance of hormones is as well. It's not all about estrogen. Then some people have asked about what about the right dose and type, and do I need blood tests? Like I've said before, having the right dose and type of hormone is really actually very important. So many doctors and women often think it's a one size fits all. So if they take HRT and don't feel better, then their symptoms can't be due to their changing hormones. Yet we know that actually for a lot of us, we need different doses and types. So often we do a blood test to check the absorption of estradiol through the skin into the bloodstream. We'll often do a testosterone level, and they are a guide. Our hormones will fluctuate all the time, but it will give us a guide. And if I see a patient who has some symptoms, their estradiol level is low, then I will talk to them about either changing the formulation to try and improve absorption, or increasing the dose to try and increase the absorption through the skin. So it's important to think it's not just try this dose and if it doesn't work then HRT is not for you. It's tweaking and tailoring it for you, and we have a lot of experience in our clinic to really individualise the dose and type of hormones. And some women it's quite easy, and some women it can be more challenging, but it's really important to work with your healthcare practitioner and not be just told you can't take hormones because they haven't suited you or the first one hasn't suited you. Someone asked about fibroids. I've done a great podcast actually about fibroids with a gynecologist called Osami Naji, and there's some information actually on balance as well. Women can take HRT if they've had fibroids. Fibroids might be symptomatic whether people take HRT or not. So it's important to again tailor the type of HRT with your healthcare practitioner to try and minimise your symptoms as well. A few people have asked about what about if I've had cancer, especially breast cancer. I've been told I can never take HRT. And I'm going to do a whole Instagram live soon for women who've had breast cancer because it's so important, and these women really are neglected. A lot of people become menopausal because of their treatment for breast cancer, and a lot of women are not told about the myriad of symptoms that can occur and actually the health risks of not having those hormones. And quite rightly, the focus is on having the best treatment for the breast cancer. But looking longer term, as people's outlook is often very good from breast cancer, it's thinking about the potential effects, not just to quality of life, but future health for menopausal symptoms. And we know from our studies, we had one published last week, we've got another one coming out next week, looking at people's experiences of being told about menopause and being offered treatments for menopause after breast cancer. And the results are really quite shocking and harrowing because women are really, really neglected. We haven't got good data about taking HRT after a diagnosis of breast cancer, and often there are different types of breast cancer, there are different stages, there are different grades, and each woman is an individual and you should be treated as one as well. We balance and weigh up any risks with any benefits in an individualised way. So anyone who's had breast cancer, if you have been told you absolutely can't ever have hormones, then it would be worth talking to someone who understands hormones and has experience as well, because it's a very individualised choice. And I'm not here saying that people should or shouldn't take hormones, but I'm here saying that people should have the opportunity to discuss them if that's what they want. Certainly there's increasing evidence now that people who've had breast cancer, even if it's estrogen receptor positive, can use vaginal hormones. So either vaginal estrogen, there are different types of pessaries, creams, gel, there's a vaginal estrogen ring as well, or using prasterone, which is intrarosa in the UK. This is DHEA, which converts to estradiol and testosterone in the vagina and the surrounding tissues, including the urinary tract. And these women who've had breast cancer can usually safely use vaginal hormones because they don't get absorbed into the rest of the body. So whether they take systemic HRT or not, then considering vaginal hormones can be very, very helpful and often transformational as well. Some people asked about, what about the age of stopping HRT? When do I stop? Well, I've already said it's an individualised choice. The guidelines and the evidence are clear that women can consider continuing HRT for as long as the benefits outweigh the risks. And for most of us, the benefits do outweigh the risks. We should have an annual review with our healthcare practitioner. And certainly in our clinic and our annual review, we usually offer estradiol blood tests, testosterone blood tests, and we usually do well woman blood tests. So we'll look at thyroid, we'll look at B12, folate, we'll look at ferritin, iron level, we'll look at the HbA1c, which is the average glucose level, we'll do cholesterol, we'll do blood count, we do liver test, we do kidney test, do a real check to make sure that everything else is fine. We'll do blood pressure obviously as well. And then we spend a lot of time actually in that annual review talking about exercise, about nutrition, about lifestyle, about mental health, whether people need to take any supplements or anything. Make it really individualised to improve health. So menopause consultations are not just about hormones. They're looking at that person as an individual, trying to really optimise their current, present health, but their future health as well. Because we know most of us as doctors, and also all of us really as patients, should be working to reduce diseases going forwards. It's not just about managing symptoms or treating diseases. We want to prevent diseases, and we know that obviously hormones have a role, I've already said, at reducing really common inflammatory diseases, but also we've got to take into consideration our lifestyle as well. And often when hormones are balanced, then it's easier for us to then look at everything else that maybe we're not doing quite right in our lifestyle as well. But often speaking to someone who understands, who's got knowledge and experience, is really important as well. And that's why it's important when you see a doctor, it's someone who's very holistic, who treats you as an individual and puts your concerns and expectations of that consultation really central to anything that they do. So it's so important in my mind, more and more actually, that we are just listened to, that we are understood, we are treated as very individual people, because that's what we are. And certainly in my clinic, I always treat people in the way that they would want to be treated, in a way that gives them a lot of respect, but also choice, because life is a choice, isn't it? And for too long, women's health has been neglected, and the choice of whether we take hormones or not has been neglected as well, and many women are not able to receive hormones if they want them. So I hope this Instagram Live has just given you a bit more information, maybe a bit more confidence to think about what you want. And if you do want to consider taking hormones, then it's not unreasonable to ask for a trial of hormones. And if you don't get the right help, support, advice and treatment from the first healthcare practitioner you see, you certainly can ask for a second or third opinion. None of us mind if you go and speak to someone else, because, you know, our hormones change, they become low in menopause and they stay low forever. So for most women, it's going to be decades of having low hormones. And we need to be able to make decisions as to what's right for us at the time that's right for us as well. And we're also allowed to change our mind. So if we want to stop hormones or if we want to start them, it's absolutely up to us as well as individuals. So I hope that's been helpful. This will be uploaded onto my YouTube, and I look forward to speaking to you next week. So enjoy the rest of your evening if you're in the UK, and have a great week ahead. Thank you.